So today, everyone, we have a great talk and presentation on skin health and wounds with spinal cord injury. And this came from a suggestion actually from Ryan, who's also on this session with us, who works at GFS Strong in our SCI Resource Center, who mentioned that there's a lot more posters and information being shared around GFS Strong about pressure injuries. And it's something that affects our members a lot frequently. And it's always an important topic to talk about and know how to reduce your risks and prevent injuries from forming and know what to do when you see a trouble spot. So we're really excited to have two, I think, folks that will be fairly familiar to most people, Shannon Sproule and Regina Colistro, who are both physiotherapists with the GFS Strong SCI outpatient clinic, as well as Shannon works with the SCI wound clinic at VGH. And Erin Schmidt is a nurse who's also with that same SCI wound clinic, who's agreed to also join to help answer some other questions. So thank you all so much for joining us. And I just want to let everyone know that we're going to let Shannon and Regina start with their presentation. So without further ado, I'm going to hand it over to Shannon and Regina.
Okay, so I'm Regina and I'm going to start the PowerPoint. We have a short PowerPoint that we'll kind of lead off with and then open it up to all questions. Erin will interject whenever she feels it's appropriate. Just fire off there. It's pretty informal, and now that we've got our techno glitches out of the way, I think we'll go. So our topic is skin and wounds. We're talking about injury prevention and treatment. So it's estimated that up to 50 to 70% of all people with a spinal cord injury will get a pressure sore or pressure injury, where it's the current terminology is pressure injury, at least once in their lifetime. This data does not include other skin injuries such as burns, trauma, dermatitis, etc. This 50 to 70% can vary. It depends on really what country the research is coming from. And obviously people in resource poor countries will have a much higher incidence. But we've got 50 to 70%. So, but the incidence is quite high. Pressure injuries can affect your participation in life and severely restrict your activities. Anybody who's had a pressure injury will know what's involved in reduced participation, as well as it really curtails your lifestyle. Pressure injuries can be prevented. This we know. So our outline is, number one, the common causes of wounds, why your skin is at risk of developing wounds, why it's important to recognize and manage red spots, how you can prevent wounds, what you can do if you get a wound, treatment and prevention options, and finally at the end we'll have questions and discussion. Okay, so the main causes of wounds, so skin issues. Number one, pressure, direct downward force, usually over a bony prominence, preventing blood flow to the skin, resulting in a round area of tissue destruction, and will usually be deepest in the middle where the bone is. Shear is when two layers of tissue next to each other are pulled in opposite directions. Shearing and pressure forces often work together and result in irregular shaped wounds or wounds with undermining. Spasticity, exercise, bed positioning, those are things that are affected or are involved in shearing. Friction is the constant rubbing or pulling of skin across surfaces. Factors that can be affected with friction are sling application, close pulling. Okay. Causes of wounds. Now we also have trauma. So trauma is like an injury to body tissues from an outside force, such as your foot hitting the foot plate or furniture, elbows banging on walls. Those are all things that are like a traumatic event. Burns are damage to, when there's damage to body tissue from heat, could be direct or indirect, such as a plate or a cup on your lap, the sun, heater, or hot packs. Dermatitis involves itchy, dry skin or a rash on a swollen, reddened skin. It may cause the skin to blister, ooze, crust, or flake. And factors that are involved: incontinence, sweating, adverse response to topical products.
And often the incontinence, you will, and Aaron can share a lot more with this, is that products are often put on that actually can cause the dermatitis because they put on some products, but we can get into those in more detail down the road.
Okay, how can you prevent wounds? You check your skin daily. We call it a 24-hour assessment because it's throughout the day. Doing regular weight shifts. If a red spot, stage 1, occurs, you seek it out and remove or address the cause. You ensure your equipment is in working order, and that includes your mattress, wheelchair, your commode. This is padding, I can't see this last one. Padded shower seat. Maintain a healthy diet, maintain a healthy weight. Skin health, moisturizing, hygiene, avoid smoking, manage excess moisture. Okay, sorry, that was a bit sketchy over there. I'd like to move that over, thanks. Okay, how to spot new pressure. Stage 1. So stage 1 is redness that does not go away after removing the cause of pressure. And that's usually within 15 to 30 minutes. We look at blanchable versus non-blanchable skin. Non-blanchable is a stage 1 wound. So blanching refers to when you press on the reddened area, it should turn white. If it doesn't turn white, it's a stage 1 wound. Okay. How to spot new pressure. Stage 2 wound. The skin is open, but just the top layer or two. So you can see from this picture, it's just the top layer, top 1 or 2 layers. Stage 1 and 2 is when it's most important to take action to prevent progression to a more serious wound. A purple or bruised area may be an area of deep tissue injury. A non-circular wound usually indicates shear or friction. Okay, how to spot new pressure continued. Blisters can be a sign of pressure damage. A callus can be a sign of friction or shear. Okay, so now I'm going to hand you over to Shannon, who's going to talk about, so you have a wound, what do you do?
So you found that you have some kind of wound, and you, if it is a stage 1 or 2, you should just try to address it, and you want to try to promote that wound healing as soon as possible. There are some phases to healing. I just identified there: inflammation, proliferation, maturation of the tissue elements around the wound, and you want to try to allow that to happen to enable the wound to heal. The action that you can take, you can't, your action can help that happen in your body. So you want to do pressure relief. You want to go, whatever is causing that wound, you want to get rid of that aggravating thing. Debridement may be something that you do to optimize wound healing. You want to control any bacteria or infection if that happens. You want to optimize your nutrition and diet, make sure you have the right amount of protein, and that'll all depend on where you're at with the wound. If it's a stage 1 or 2 wound, you're not looking at debridement, you're looking at the early stages of trying to address the wound. And then you want to prevent the reoccurrence. So once you see you have a stage 1 or worse, you want to know exactly where it is. And so you have to really look and make sure is it over a bone? Is it really know where it is, then know the stage and the size. And the reason you want to know that is then whatever action you take, you can then determine, is that action making the wound smaller and the stage improved? And so you always want to have those measurements to look at, is the various treatments you're doing and the changes you're making helping? You want to look at the peri-wound, and by peri-wound, and you jump in, Aaron, if you have anything to add, is the skin around the wound, because that can tell a wound nurse, as Aaron is, a lot of information. You want to know with that wound, is there tunneling, which is like you have the open wound, but then you can have a tunnel under that. And that could mean that there's a lot of friction and other factors that are irritating that base. So that can need some very specific wound treatment. Is there exudate or liquid coming out of the wound? What's the color of the wound bed? Is it nice and red, and does it look like there's healing happening, or is it yellow and look like it's infected? Is there dead tissue? That's what necrotic tissue means. Is there granulation tissue, which indicates some healing? And that, by all of that, if you monitor the wound, you can then determine the effectiveness of your treatment. And your treatment isn't just what you put on the wound and how you treat it, the things that Aaron prescribes. It's also the changes in your behavior, the surfaces you're on, your diet, all of those kind of things. So there's non-surgical treatment, which is always conservative treatment. Non-surgical is the way you try to approach things first. So you want to search for and remove the cause. So if you were, sitting on a hard surface, you went camping and you were down on the ground with nothing under you, well, then you want to say, okay, I can't do that. So do I need a cushion for camping that I put under me? Or so you really have to do the detective work and really find out what has caused that irritation. And if you catch it at the stage 1 or 2, there's very good research to show if you find it, address it, then often you can get rid of it. If it goes to stage 3, 4, it becomes much more challenging, and you often are looking at quite a prolonged period of trying to heal it non-surgically, or you are just needing surgical treatment is the problem. When you have a stage 3 or more, you really do need to contact your health team and probably be seen by a wound nurse to look at the appropriate types of treatment. So you can have direct wound treatments, dressing modalities. There's besides the dressings and things, there's other gizmos now that they use, negative pressure therapy. And they're called either the VAC or the PICO. You may have heard of those names, and you can ask any questions about that later. But the big thing, again, is changing your behaviors and or equipment or whatever you have discovered is the cause of the wound. So when you have a wound, you do have to do direct wound treatments, and it'll be determined, is it once a week, 3 times a week, and a lot of that will be determined on the state of the wound, how much exudate or fluid is coming out of it, how infected it is. So there's a list of all the possible things that you might do to directly treat the wound. And if you have any specific questions about that, we can get into that. There is a lot of possibilities because there are a lot of products to treat wounds, and Erin knows them all, so she can answer any questions about those. But the principles of dressings is you want to keep the wound moist and the surrounding skin dry, which can be very challenging with a lot of SCI individuals, and especially so often they're on your bottom. You want to control the amount of fluid that is coming out of it so you're not totally wet all the time, and prevent infection. And you don't want to, the reason you want to have a moist bed is you don't want to have a dressing come off and then rip the skin off and sort of open up and start bleeding again. So, and there's some general principles of dressings. You want to make sure that the wound bed is filled, but you don't want to, put a whole bunch of stuff into the wound. So you're really pressing a lot of the dressing or however you're treating the wound bed into it. So there's a fine kind of science to how to dress wounds. And it really does depend on the size and the type. So these are just a few pictures of certain types of wounds and some of the possible choices you might make for dressings. And there are a lot of really, all innovative products coming out all the time. But one of the big things lately in the last number of years has been these dressings that you can put on, and it turns the dressing into kind of a gel so it can absorb some of the exudate if you're having a lot of fluid coming out, and it helps keep people dry, and so that the periskin or the skin around the wound doesn't get all what's the right word, Erin? Macerated. And that can happen if there's, how when you're in a bathtub for a long time or in water and the skin gets all macerated, you don't want that to be happening. So for, these are just some of the features of ideal wound dressings. And so you're trying to juggle all the things about what type of wound you have and how to make a wound dressing that will meet all of these needs. So surgical treatment. So if you get into the stage 3 or 4 wounds and the wound has been open for a very long time, or it's looking like it's got a lot of dead tissue, sometimes you have to do debridement, and Erin does that, or the surgeon, to take out actual dead tissue, or sometimes open up the wound. If sometimes a wound can close over and have an open cavity, but the wound closes, and that's no good. You want to always heal from the bottom of the wound. A primary closure is a more simple surgical procedure where you can cut out a bit of the infected or the wound bed, and then just stitch the 2 pieces of skin together, because it's small enough that it allows that. A lot of the wounds we see, I mean, we can see wounds, that are quite large, and you just could not do a primary closure because it would just pop open again. So you're having to look at moving some tissue to cover it, cut out the wound, and that's where you get into skin flaps. And so the surgeon is having to cut a piece of skin from somewhere close by that has a blood supply, and then flapping it over to cover that wound that's opened. And it's a very big surgery, and then you're having to be immobilized for a while to allow all that, the open incision lines, or the incision lines from the flap to close. So you can't bend at the hip and knee, so you usually are not sitting up for a few weeks, and then you can start to mobilize. The thing about skin flaps is there's only a couple that people can have, because there's only a few choices of areas where you can move the skin with the blood supply. A lot of times people think they can get skin grafts on big wounds, and that is just not possible. That will not heal a wound, any kind of a big pressure wound.
And if I can interject,
Pardon me?
in the realm of flaps, I mean, we're moving muscle and we're moving tissue, we're moving skin.
Yeah.
And so when we have a big IT wound or a big sacrococcyx wound, and we're borrowing a piece of muscle from, say, your buttock, that is very small, because people who have, not been walking for years, they have thinned out muscle, they don't have as much subcutaneous tissue anymore. So when we borrow, it means that we have less chance down the road to borrow again. And so when people are paralyzed at a young age and they already are having large wounds early on in their paralysis, that means you kind of decrease the amount of times you can have a flap in the future. So we really kind of harp on trying to avoid getting a flap. If you can fix yourself, notice that you have a wound, and try and figure out the cause, because as wound care, I don't really fix you. It's more the OTs and PTs and all their offloading. I just kind of bring a little bit of pizzazz to it and help the wound either be moisture controlled, decrease some of the bacteria load while you do your own healing. So when someone has a flap, it's kind of sad because it reduces their chance down the road. Say when they get sick, they get into ICU and they just their skin just can't handle what's going on. And it is quite a surgery, to the point where, to the next one is, if you've run out of options and you still have a large wound, we will be amputating your leg to bring the flap, and that's what the amputation with skin flap is. And we've had to do that a few times, where we actually fully take off at the hip joint to use that excess muscle and flap to cover a big IT wound. And when it comes to that, we also have to kind of consider putting in colostomies on you, suprapubic catheter, because we really need to divert the stool. And sometimes the stool is half the problem and to be part of the cause. So those are surgical treatments, and they're not to be taken lightly. If I can heal, or anyone can heal themselves first, that you creating your own tissue instead of borrowing is a better scaffolding of your skin than borrowing from another spot. So that's kind of why we harp on it and say things over and over again.
Yeah. Yeah, you'd rather, that's the importance of preventing getting a wound in the first place. So this is just what is it called? Mnemonic.
Yeah.
So that you really have to look at the whole person. What happened? Where, why, how, when did you get it? Because that really can help you in addressing it. Then you want to know about the whole way wounds heal is by getting oxygen to them. You need to find a way to get oxygen. So that's where pressure relief and allowing oxygen to get to that wound bed. And that's why you either go on bed rest for some periods of time. We want you to have an offloading cushion, or do pressure reliefs. Not smoking is huge. Smoking is a bigger risk, and it really does affect the amount of oxygen getting to your tissues way more than people are aware of. And Dr. Papp, who is the surgeon in our wound team, won't do surgery on people that are smokers because the fail rate with smokers that have had a flap is quite high.
Each cigarette that we smoke, the amount of nicotine reduces perfusion to our skin for 90 minutes approximately. So if you're smoking once an hour, you basically have vasoconstricted your small peripheries to your skin, which is also to your wound. So basically, the only time you kind of heal is at night when you're not smoking.
Yeah. So then there's the underlying factors, age, all of the age, the lack of mobility, psychosocial issues always can be a factor, because they can just affect your mobility and your initiation. Continence, if there's a lot of incontinence, it can be a huge problem if the wound happens to be in your buttock area, which a high percentage are. And that's why we go to, like Aaron said, to colostomies and various things. It can be quite helpful for healing. Nutrition is huge. You need to have a high protein diet and make sure your other vitamins and minerals are appropriate. So we have a dietitian also associated with our clinic. So you want to look at the whole person is the basic importance. And as we went over, you know, we do see at the beginning, we talked also about trauma. You know, we see probably 25%, would you say, Aaron, of the people we see in our wound clinic have significant foot wounds. There are a lot of wounds people get on their feet, and feet wounds are very slow to heal. And it's because your legs are hanging dependent. You don't get the circulation and the oxygen getting to them. So they can take a long, long time to heal.
Gemma, you have a question?
Yeah, we had a question come through in the chat, wondering if BioFlex cold laser therapy has ever been an option that's been tried.
I've never heard of it. BioFlex.
Yeah, I don't know but laser is something, there certainly has been research on using laser on wounds. We do not use it. Here we do use E-stim, which is a high volt pulsed current. And it has been quite successful. The inpatient team here at GF Strong uses E-stim on quite a few of the clients, and it can be quite effective in helping bring the things for healing the wound to the wound bed.
Right.
Angie?
Yeah, Angie, you want to unmute yourself and you can go ahead and ask your question.
Okay, yeah, thanks. I might try to just squeeze two questions in. The first is that, as you mentioned, wounds can deteriorate pretty quickly. What's your best advice on quickly seeing a wound nurse? Just the referral process through GPs is quite slow these days if you have sort of a best route to go. That was my first question. My second question was about, Shannon, you mentioned sometimes wounds heal from the bottom up. In other words, it might not look open at the top, but there's something happening underneath. And I'm just wondering how that happens or what could be the cause of such a wound.
Well, I think, and Aaron could speak more about the wound healing from the bottom. That is what we want to do, is have it heal from the bottom, but you speak to it, Aaron.
Well, first with referral to a wound clinic in the community. I know with Vancouver Coastal Health, you can refer yourself.
One sec. I don't know, your mic or something is a bit muffled and it's kind of hard to hear you. I don't know if that's the case with other people, but it's just.
Can you hear me now?
I can hear you. It's just kind of muffled, I would say.
It sounds a little underwater. If maybe just speak a bit louder and we'll caption for you.
Sorry. With community referrals, I know with Vancouver Coastal and with Fraser Health, you can actually refer yourself. You don't have to go through a GP. And if you Google Vancouver intake, I think you can find the referral form yourself. So that would decrease having to wait to go to your GP. Is that okay? You can hear me?
Yeah, I'm just wondering, how would you refer yourself?
There's, I have the referral form right here. So maybe I'll put it in the chat.
We can maybe put it up to share it.
Yeah, we'll find a link and post it in the chat in a second, Angie.
You can also
to Google Vancouver intake to find the self-referral form for community wound nursing.
And you can also phone your local health unit if you know it, and ask, say you have a wound and you need a nurse to come and assess it.
And you have a spinal cord injury as well. It's really helpful to say that because they'll take it very seriously.
Okay.
With the wound question, so I think I caught two things you're saying. So when a wound starts from the top down and we see a normal wound, the wound then has to rebuild, yes, from the bottom up, and the cells kind of fill in from the bottom and they work their way up. There are wounds that start at the bottom and you don't see them, and those are called deep tissue injuries. And those are typically, you had, sorry, sustained pressure. Say you were, in an emerge, you see an emerge where people have been sitting on a really bad stretcher. And all it looks like is just a simple bruise. And then it can take up to 2 to 3 weeks for that bruise. And dead tissue is started at the base near the bone, and it kind of tunnels its way up to the top of the skin. And then we see the sort of, it kind of declares itself. And then we know what's really going on. And those we can't tell until they've either declared themselves. Sometimes they're just a simple bruise that kind of with offloading can reverse itself. And sometimes we see the wrath of it a couple weeks later, and then we clean up your wound, and then we have to rebuild it. Does that make sense?
Yeah. I wondered too if maybe a shearing created an infection and it penetrated somehow. I don't know if that's possible.
Sometimes you never know the etiology. You just start knowing, like as a wound clinician, I can visually see oh, something's coming.
Yeah.
Oh, okay, I'll see you next week if something's really coming. And you kind of just learn over time that anytime you see a deep bruise on your ITs or your sacrococcyx or your lateral ankles, then we kind of go, oh my God, and you wait for the storm or it goes away. You never know.
Thank you.
And the detective work is really hard sometimes because you've maybe been living very healthy. And I know this was for anyone that transfers using a transfer board, there was someone who was quite slim and she was putting the transfer board under, her hip to transfer. And all of a sudden, one time this wound opened up there. And it was like, why did that come? And we looked at her cushion and her seating and her bed and, everything. And it turned out she was jamming that bone every time with the transfer board. And she didn't have sensation, but so sometimes it can take quite a while to really figure it out. And so we did alter how she transferred and finally addressed it, but it can sometimes take quite a while. But the aim is really to try to find out what has caused this.
We have a couple of questions in the chat. I just wanted to respond to one of them to Brandy, who asked what's the best way to get seen if you're not in Vancouver. In my experience in Island Health and a few folks from the interior, the best thing is to let your doctor know and at the same time call the community wound nursing clinic, whatever it's like your community health clinic, and tell them you have a spinal cord injury and you have a wound, then you need to be seen immediately. And I know Erin and Shannon can probably tell you what the scope is for the SCI wound program, and they do see people via telehealth to a certain degree, but the scope is narrower.
We definitely prefer people to have been started to see in the community because our clinic isn't, every day. So we need that support from the community, and we kind of require it because when we see you and we have suggestions, whether it's your care or a wound product, we actually have to send that information to someone. So being attached to community is kind of part of our scope. And then sometimes they'll do more extensive seeding at GF. And so Shannon and our OT Cynthia will see people behind the scenes, but at least they've kind of gotten some good information on what they need to do. We also have a physiatrist attached to our clinic. So if you have spasms or pain or bowel and bladder issues that have kind of created the wound, then she will help sort of sort that out. And sometimes that itself can fix the wound, and then you really don't need surgery. But then you have the plastic surgeon as well, just in case.
Yeah, and we do see people from all over the province, and we will do Zoom or telehealth assessments with either the physicians. Lots of times the physicians will join the call with the client, or we've done seating assessments by Zoom with the OT and PT. So we're pretty open to try to assist in whatever makes sense.
Another good reason to talk to your community health clinic first is that, to my knowledge, you can't get into the SCI wound clinic until it's stage 3. Is that right? And more so my experience is like, get to know your local community wound nurse team. They're very good. They might not be SCI specialists, but they are wound specialists, and they can be very good allies and people to know, and that referral period is much shorter.
Yeah, great point.
Scott had a question. Has there been any or many hyperbaric oxygen therapy trials done for pressure sore treatment?
I think there is research, and I believe it's not been effective.
The SCI, if then the local team that's looking after you, if your wound progresses to stage 3 or 4, then there is a referral form as well, which we could get the link to for the what do they call it? Spinal cord impairment wound clinic. I think it's what it's called.
That's your clinic?
Yeah.
Okay. Do you want to continue with the presentation?
Yeah, I don't
Cindy's
know how
got
many
one.
slides I have left.
One.
Oh, here. So here's the big sum up. So during a skin check, you or your caregiver discover a red spot. What do? So first step, identify and treat the underlying cause. So really try to get after that, review your surfaces, your transfers, try to think what happened in the last 24 hours that made this come up. And the 24-hour period, like Regina said, often you want to do a skin check in the morning, because if something's red in the morning, it's telling you maybe something happened in the bed. Do you have a red bone, ankle bone? Do you have a red hip if you're a side sleeper? Or do you have, so that helps you narrow it down. If you're red, you get it back into bed after being up in your chair all day, and you find something red. Well, then that tells you, it seems like it's from my chair. So it kind of helps you at least start to narrow it down to figure out what happened. And that's why we recommend an AM and a PM skin check to try to help figure out who where the injury maybe happened. If the red spot is worsening, not improving, despite some self-assessment and changes, then you want to get some health professional. And like we said, that's when you look at your local health unit is really the best place to go first. And whether you're in residential care or living on your own, you want to address the people that are caring for you or you have a relationship with. And then you contact, if you're connected with home health and maybe they're coming in already to do some of your care, then let them know and have them come in right away. If you are pretty independent, not requiring any care, then get yourself referred to home health, like Erin said, and just start getting help and getting it addressed as soon as possible. I think that's it.
I think Cindy has a question.
Hi there. Yes, I'm married. I have MS and I've been a wheelchair user for over 20 years. And I'm married to a chiropractor and he does the Bioflex cold laser therapy. And I've been worried about pressure sores before. So he's lasered me 2 to 3 times. And then because I can feel sensation, the pain went away. I just wanted to share that it's been great. It's been amazing. Right now I'm like shifting around because I'm like, I'm waiting for wheelchair seating. I just ordered a new wheelchair and I think the cushion I have is not working. So I'm like hoping kind of like, okay, need to find some solutions for this. So yeah, but the Bioflex laser therapy, I mean, there's other people out there. I'm not like, I'm trying to sell him or anything, but it was a great option for me anyways. So I'm hoping it could help other people.
Yeah, yeah.
Thank you.
Jenna, do you want to share some of the questions in the chat?
Yes, so we do have a question from Angie. She's just wondering how big a role does weight play in developing sores?
A lot. Even being underweight can cause pressure injuries, and definitely being overweight can increase the risk of pressure sores a lot quicker than an average weight person.
Right.
Yeah.
Ryan has asked if there are any vitamins or supplements that can help the healing process.
To be honest, not really. If you actually eat a pretty basic average diet that, has your typical fruits and your vegetables and some rice and grains, meat if you are a meat eater, if you're not a meat eater, like some tofu or whatever. Really, it's actually about what you're not going to eat, like Kit Kat bars and Coca-Cola. That would be better to be out of your diet. And putting in actually some real food will make your wound heal faster once you kind of remove our lovely North American horrible food. So it's actually removing the bad and just letting the good normal food do its job, and your wound will be happier for it.
And if you get a stage 3 or 4, like a very big wound, and we sometimes see, just huge wounds, to heal those, you do need a fair bit of protein, and sometimes it's more protein than what people are used to eating. And the dietitian can help with calculating to make sure you get enough. And sometimes people will take, Ensure or some of those supplemental drinks to help get the right protein.
Gordon has his hand up.
Yeah, hi. I was wondering what about a quadrupro? If you're not seated in the same place from day to day, is that likely to cause problems?
And by seated in the same place, like you're not positioned.
My butt wouldn't be in the same place from day to day. I mean, you lock in all 4 quadrants, and if my butt's not sitting in the same place, would there be more pressure in one part than the other?
Yeah, I think you may be taking pressure in slightly different places. The bottom line always is do a skin check. If your skin is tolerating it, then it probably is okay. The best way is to really do daily skin checks, and because we have to be able, we want you to move, and we want you to be able to shift your weight and weight bear through different, slightly different parts of your body, because there's health reasons and benefits for doing that. Right. And so the bottom line is doing a skin check, and if that's the way you're seated and your skin generally is safe and intact and not red, then that's indicating what you're doing is okay.
So that's another question was, how much of wound assessment is done when HEAs are trained? Because I have to continuously ask for it. Nobody bothers to check me on a regular basis.
So how, for a skin check, you mean?
Yeah,
Okay.
like, is that part of their training?
If you have, are you having?
I'm in residential care.
Oh, residential care.
Yeah.
I mean, typically we recommend you, as they sort of undress you, often it can be incorporated into personal care that they're doing for you, that they just look at your skin. And if there's something that's red, they should just do a poke and make sure, is it blanchable? And if it is, then that's fine. But that should be part of, we would recommend that would be part of regular personal care, and would be incorporated either into your dressing, showering, toileting.
Okay.
Yeah.
Good. Thank you.
Of note, if you're getting someone to shower and bathe you, and if they notice any sort of areas around your buttocks that have a bit of dry skin, is to ask for them to put a little bit of lotion, just regular lotion on. When your skin is nice and hydrated, it can take a little bit more trauma. So when skin gets dry, it gets a higher risk of damage and breakdown. So even asking that, like, is my bum a little bit dry? And they get to rub a little bit of lotion on it.
Is that the silicone-based one?
You only need the silicone-based one if you are a little bit incontinent. Then that silicone puts a little bit of a barrier on your skin, so the next time you're incontinent, it takes a little bit longer to penetrate that sort of urine and feces enzymes into your skin. But if you're not incontinent and your skin's just a touch dry, it's just basic, Vaseline or a Vino lotion.
Okay, thank you.
Gordon, just a tip from another peer I've heard, that when you rely on people to do the skin check for you, it's also good sometimes to periodically ask them to take a picture to show you, because sadly they don't always tell you the truth.
I see. Okay, thank you very much.
I can add to the photo. Because caregiving often can vary from day to day, and you may not have the same person who's looking at your stage 1 or stage 2, or if you have a picture on your camera, then you can have a sequence of pictures over the space of time, so you can actually see if the wound is getting better or worse visually. So we often recommend that people take pictures on their phone, or have your caregiver take a picture on your phone, so then you can see. And then if you need to show the wound nurse when they do come in, then you have a visual and you can see how the wound is doing over time.
So,
Angie?
yeah, I finally unmuted. I wonder if any of the speakers have a suggestion on sort of a go-to product, when you're at that first stage where you've relieved pressure and you're still concerned. Is there, I know, Shannon, you mentioned the gel-based, but is there something, say, we should have on hand just for that early stage where we still feel like it's within our control to manage it? Yeah, that's kind of what I'm looking for.
I mean, Aaron would speak better about the products, but when you're at a stage 1 and nothing's open, you don't need anything on it, right? So you start putting dressings on when the skin has opened, and what you're wanting to do is protect it from infection and help it heal. And Aaron, there is a sequence of events to try to promote that and assist that with happening, and Aaron can maybe speak a little more knowledgeably about that.
If it's a stage 2, where the skin has kind of just broken, and it's not too wet and not too dry, I typically use a product called Inadine, so INADINE, and it's actually just an iodine impregnated mesh. It's cheap and cheerful. It adds just a little bit of antimicrobial just in case there's a couple bugs laying around. And the wound seems to do well with it. I like to put on Methylex borders. They're kind of moisture retaining dressings, but any dressing over top is fine. But the Inadine mesh doesn't stick, so it's not like it's going to re-traumatize the wound when you take it off. And when you take the dressing off and the Inadine it's yellow, but if the dressing, when you remove it, is white, then I know that you have more bacteria, because that means the wound has kind of used up the antimicrobial of the Inadine. So it's a good indicator for me if you've got more bugs going on. And if you have more bugs going on, then I kind of shift what I use. So Inadine is cheap, it's cheerful. Most people are not allergic to iodine. It's not traumatic. And it's kind of a good indicator if your wound bed has bacteria or not.
Thanks.
By the color.
That's so helpful. Jocelyn tried to spell it in the chat. I didn't quite get the spelling. IMAGANE.
Sure.
D.
There.
Inadine, okay.
Okay, thank you. Perfect.
I can attest to Methylex border as well, because I have very fragile, like thin skin in my trouble spot, and the last way it was dressed when I did have a wound, and I have a lot of trouble with adhesives tearing my skin, and they're very gentle dressings if a dressing is needed, and it isn't always needed, but so I keep them. When they bring them over, I just store them away, and if I ever need one. And they're quite useful just generally to avoid that, like problems with adhesives and that sort of thing. So, which is nice. Erin's saying she read the product how-to, and for application has some issues in areas that aren't flat, which is almost everywhere. I know my skin's not flat. I think Jenna had questions from someone else.
Yeah, I have two questions that I received prior to us starting. One is that a participant mentions that the last time I got a 3-inch surface scratch on my leg, it became infected. The leg also swelled so much that even my toes were swollen, and that stayed even after the scratch healed. And she was just wondering if you had any best management practices for that type of situation.
Yeah, I mean, obviously cleaning the wound, noticing the wound as soon as possible and giving it a good clean. You can even soak a wound in a bit of Epsom salt to draw anything out, hopefully decreasing infection from taking in. The swelling definitely was an indicator that there was a bit more colonization of bacteria going on. And once that's taken in, the tissues definitely swell, and it does take a long time to reduce. Once you're, let's say you had to go on antibiotics, once you're on some antibiotics, putting on a light compression, if you have an OT or PT in your world, asking for a single layer tubey grip or something similar can start to reduce that swelling. And if you think about it, you've got your vessels in your leg, and you've got your outer layer of your skin, and you've got micro vessels going from the big vessels that bring oxygen and blood back and forth. And if you've got that much edema, it takes a lot longer from the oxygen and the good cells, nutrients from your big vessels to get to the micro vessel, and basically it has to swim through the skin. So if you can start compressing after the initial redness goes away, then you will decrease the swelling, decrease basically the swimming pool going on in your tissues, so that the oxygen and nutrients have a shorter distance between your good vessels and your wound bed, if that makes sense. So something like that is good, but yeah, it does make sense that the edema stays around. And being that you have spinal cord injury, removing that edema from a dependent area can take a lot longer because you don't have that, the pumps in your legs. When we walk, we can shift a lot of fluid off of our legs, and being sort of paralyzed, unfortunately, decreases that. So using a light tubing can do that action for you so that you can get your leg down and get more nutrients in a shorter distance.
Awesome. Great. Thank you for that. I can pass that along. And one other question we did receive was from a participant's or a peer's mother. She's just asking if there is, whether or not you know of any pressure sensing device that would go under the ROHO and advise if the inflation becomes too low, or if the individual is bottoming out anywhere on the cushion.
I mean, we definitely have just the manual checks, which I'm sure they've been taught that. And the ROHO website is really excellent. They have videos and printed material showing how to check for inflation. ROHO now has something called the Smart Check, and it's a little device so that you can have a therapist set up the right inflation, and then you put in this little Smart Check, and it'll say green thumb or a red X. If it's inflated properly, it'll say everything's fine, and you just leave it. If it's too low, then you have to pump some air into the cushion until you get the green thumbs up. And it's quite a good device. Unfortunately, ROHO has it only for a single valve cushion though, not for the Quattro. And I know a lot of people use the Quattro, so it's not great. The only other thing is pressure mapping, but it's not something that, people have every day. There certainly is discussion in the whole, research and development of maybe having something like that could be incorporated as part of the cushion to help when people are using air anyway, but possibly even other types of cushions to help give some feedback on high pressure areas. But presently, that is what is out there.
Okay, perfect. Great. Thank you.
I remember a few designs coming across my desk when I was at RHI. There was one that was like connected to a smartphone app that would give you it goes under your cushion, and they never seem to get into like commercialization though. I've not seen one that's an actual like off the shelf, you can purchase it or order it. So we have, do we have any more questions? I know I have a question. I have been using a wheelchair since I was 9, and I've had a couple of wounds all on the same spot. And I am now have one very skinny half of my butt and one not so skinny half of my butt. And here's my question is, can I get a butt implant? I would really like a butt implant. No? Please? I just need padding. I'm having trouble with a lack of padding.
Well, Dr. Papp has done fat grafting.
Yes, but it's also failed.
Pardon me?
Well,
the first one failed. So that is being looked at, but not a whole butt transplant, no.
So really what you're missing is muscle on that side. And it's the muscle that protects between your bone and the outside. So do you get spasms on one side versus the other? Is that why you've got one butt?
No, I just, my first wound was when I was like 9 or 10, and I have a bit of scoliosis, so I lean a little lower on that side.
Okay.
And so I have like one, I guess, normally proportioned side and one I just lost all the tissue on it. So it has skin and everything, but it's so, I've so little padding there that it's just really prone to problems. So
I have had some people, Jocelyn, look at padded underwear. So you can get gel padded underwear, and I actually was looking at this at work, and I thought I might get into trouble because it's big in the male gay population.
oh, all
So
right.
they
So it's
use
like a
underwear
junk in the
with,
trunk underwear.
with like to enhance their, it's like women having padded bras. They have padded underwear with enhancing the buttocks. And there is some underwear, and I've had a couple of people that have used that to, and they just wear that underwear to give some padding. So just,
I would
so
try
that might
that.
be something, and maybe
I
you
would
could
100%.
customize it for just one butt,
Yeah,
one
that's,
side.
yeah, just to give me a little bit more
Yeah.
cover over my
Yeah.
bursa and bones and stuff.
Yeah.
Yeah, I at this point I would totally try that.
Yeah, it's a simple thing, and then you just check your skin. It might, you know, my concern is I thought it might be a bit hot. It might cause some skin problems from that perspective, but you could try it, check your skin, and see what the response is.
Sure, it's better than surgery.
What is it? What is it called? Could you even get it on Amazon, do you think?
Yes, it looked like you could buy it online, and I just Googled padded male underwear or something like that, and yeah.
Thank you.
So
I
they're,
wondered if it was like for cycling, but oh no, yeah, they're called instant butt lift underwear.
yeah, and it looks like they're for men, and it looks like it's kind of for the gay male population.
Okay.
Yeah.
Well, that's worth a try, at least for me.
Oh, nice. Wow.
Is there, I think I saw, Angie, did you have another question?
It wasn't a question, Jocelyn. I was just commiserating with you that I've been in a chair a long, long time, and I have scoliosis, which tilts me right side bottom down, and every issue I've ever had has always been on that right side.
Yeah. But what I've heard as well, probably from Shannon, but is that once you have one wound that's healed, you're always going to be more predisposed to a wound on the same place, even if you fix the trigger problem from the first wound. And for me, I was a kid and we didn't understand about the Rojo cushion and what it was for, and I just had a bad cushion that got damaged, and then I got a wound, and having like the best cushions ever has not prevented that from occasionally over the last 30 years getting another wound occasionally. And the only thing that really heals it for me is offloading, like really being dedicated to offloading completely until it shows real signs of healing. So I feel your pain. It's like, it's just a trouble spot you never lose.
Yeah, it's hard.
So I think we've gone over a little bit. So thank you to our presenters for sticking around, and everybody else. Any last questions?
Yes, I have one.
Okay, go Patty.
Does anyone have any helpful tips other than getting in a habit when doing your skin chips? I have a problem doing I'm so tired at night, and I'm so gung-ho in the morning to get going, because I'm gung-ho to get going, and I usually have to take a bus, and I want it, and I just tend to forget to do my skin checks. Does anyone have a helpful hint to make me do my skin checks a little more diligently?
Do you forget, or do you just not want to spend the time? Because you can set an alarm on your phone to remind you.
I guess so. I guess I forget, but I also, Yeah, I guess because I've had a flap before, I guess on the other hand, I think subconsciously I don't want to find anything.
Yeah.
I think
I
deep
thought that
down,
too.
deep down, I truly don't want to find anything.
And well, and you know, we've had a lot of people, and what they do to check their wound is they if they have hand function and sensation enough, is they just stick their hand and then feel like that's good enough, and it definitely is not, because if you go down and you feel something with your hand, that means it's probably a 3 or a 4 wound, and you want to be catching it before that. We do have mirrors that you can get, angled mirrors, or your phone, just to take, like, before you get up, just, you know, and you don't have to do your whole body. I mean, we recommend doing a quick whole body check, but if you know your real high risk area, if you can just quickly have your phone by your bed, take a quick shot of it, and then get yourself dressed.
I want an angled mirror. 40 years ago, GFS Strong had great ones, and I miss them. I've been trying to get one ever since. I was at GFS Strong about 5 years ago, and I was trying to get one there, and they said they didn't have any. Nobody knew about them.
Yeah, well, we have straight mirrors at GF now, but not the angle, but WorkSafe BC has those angled ones today. Yeah.
I got one from a WorkSafe BC person who had passed away. It's not angled, but it's an awesome mirror. It's like bigger than anything I could find in a store, and very light and easy to see. So I didn't have to contort myself a lot. But Patty, that might be a question for Tetra, or makers making change, because they can do 3D printed like handles for things that could be positionable. I've occasionally seen mirrors that have angled handles, but they don't stay. Like, after a couple months, they lose the staying power to position it in one spot. They kind of get loose. So,
well, that could be a good. We could assist too. We could try to see what we could find.
We can ask around, and if WorkSafe does supply them, that might mean that they're being made somewhere. So we could ask around. If we find out the name of a supplier, we'll definitely get it to CIBC.
And we'll share it with you, Patty.
Yeah.
Okay, great. Thank you.
Awesome. And Ryan suggested auto notes in your phone. I'm not sure what auto notes are, but basically same idea. Remind yourself. Some people find tracking helpful as an incentive to like check the box. My husband uses an app called Dailyo, which I believe is free, and you can track anything. So you could track like UTI symptoms, you could track sleep, but you create a little tracker for your, say, your pressure relief lifts or your skin checks, and it will remind you at that time as well. So you get the reminder, you do it, you check it off, and you get little like medals for doing it a certain number of days in a row. It's kind of like a gentle game.
So how do you spell that, Jocelyn?
Day, like DAYLIO.
Oh. No, that's
LIO, and it's an app?
Yeah, it's just an iPhone and Android app. I think you can pay extra for like certain features, but I used it for free for a while. And it gives you like data. It's, you know, if you've ever used a period tracker, it's a bit like that, but for everything, for like anything you might want to track on a phone of your life, you could track it, but it's preset for like water intake and sleep and food and stuff like that. So
Dailyo, like LIO?
Dailyo, like a day, DAYLIO, all one word. Here, I'll type it in the chat. Dailyo. And a lot of the iPhones and Androids have some kind of tracking on them in their health app. So you may already have something you just never used before. But Yeah, I find reminders do help me because I having had enough wounds, I get a little nervous about it, and which I don't get nervous about anything else, but I just don't want to. I don't want that bad news. So it's easy to like just forget, quote
You don't
unquote.
want to. You don't want to go there again. I've had
Yeah.
a flap. I just don't want to go. I guess I don't want to go there again.
Yeah, and
So,
I don't know if you've
good
ever done
suggestion.
what's it called, cognitive behavioral therapy, but one of the points to that is to play out what would happen, like play it out in your mind. If you did get bad news, if you did find something, well, you'd find it earlier than if you didn't check. Like it's kind of like, I call it like treating your inner child, like speaking to yourself as a beloved younger person who needs to hear the rest of the story in order to feel willing to do it. Just a thought.
Yeah.
Yes, I understand what you're saying.
Yeah. Well, if there are any other questions that people have, feel free to send them to Jenna. I believe you'll have Jenna's email address because of the registration. And we will send them to our speakers if there's anything after the fact that comes up, and share them back with you. Thanks, everyone.
Thank you so much. This has been wonderful.
Oh, I'm so glad. Thanks, everyone, for joining us on a very warm, sunny evening when you could have been somewhere else.
Thank you for having us.
Night all.
Very
Okay,
much
bye-bye.
appreciated.
Bye. Bye-bye.